Hello and welcome to this presentation. Today we're looking at cord management. So cord management is a slang that is loosely used to mean cardiopulmonary resuscitation or emergency care. Okay, so a healthcare provider may call or shout as an emergency for a patient with absent pulse, apnea, or inadequate breathing, ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, or asystole. There are two major goals for cord management. Number one is to restore the patient's spontaneous heartbeat and respiration. And number two is to prevent hypoxic damage to the brain and other vital organs. In cord management, we normally use the American Heart Association guidelines, and AHA, in short, recommends that the priority intervention for an emergency case is performing high quality cardiopulmonary resuscitation chest compressions of adequate rates 100 to 120 beats per minute and a depth of 5 to 6 centimeters deep. They say that the healthcare provider ought to allow complete chest recoil after each compression and should have minimal interruption as well as avoiding excessive ventilation. So to prevent a delay in chest compression, the sequence of the CPR is CAB. You start with compression, followed by airway checking and looking at the breathing. So this gives the highest priority to chest compression when resuscitating a patient in cardiac arrest. Rapid defibrillation also is the best thing to increase the patient's chance of survival. Defibrillation remains the primary importance in CPR cycle, especially when a rhythm check reveals a shakable rhythm. Okay? Establishing a vascular access and administering medication together with inserting advanced airway are important, but these should not delay the CPR. In cord management, we use doctors ABC. So we start by performing hand hygiene, then you put on gloves and other appropriate PPEs so as to comply with the standard precaution. Once we are done with that, and if the healthcare provider is the first one to arrive at the scene, the healthcare provider should verify the environment is safe by quickly scanning the patient's location and surrounding for imminent physical threats such as toxic and electrical hazard. And that is what is entailed in D. From D, you go to R, and in R, you assess responsiveness by tapping the patient's shoulder and shouting, "Are you okay?" So if the patient is unresponsive, you shout for nearby help and immediately activate the emergency response system via mobile phone. And that is what is entailed in S, shouting for help. From there, the healthcare provider should check to see whether the patient is apneic or is only gasping. Okay? If able, you should also do simultaneous check for a pulse to minimize any delay in detecting cardiac arrest and initiating CPR. If you don't feel a pulse within 10 seconds, you begin chest compressions. You need to depress the adult sternum, okay, at least 5 centimeters, but not more than 6 centimeters deep, letting the chest to completely recoil after each compression so that the heart can adequately refill with blood. You need to avoid leaning on the patient's chest, which could prevent it from recoiling completely. You need to perform 30 chest compression at a rate of 100 to 120 compression per minute. This is usually followed by 2 rescue breaths. Each breath should have enough volume to produce a minimal chest rise to ensure adequate ventilation. So guys, the process is quite vigorous and there are possible uh, complications resulting from cord management. Just to mention but a few, we have aspiration, we have broken or dislodged teeth, we could have burns, we could have cardiac arrhythmias, electrical shock, esophageal lacerations, fractured ribs, fractured sternum, gastric distension, laryngeal edema, liver laceration, lung puncture, oral or nasal trauma, subcutaneous emphysema, tracheal laceration, and vocal cord trauma. Thank you guys. We've come to the end of the presentation. Let's look at the most commonly asked questions. In order to assess for a pulse in an adult victim, you will assess for how long? How long should you assess for a pulse? Guys, in adult, we need to assess the carotid pulse and we should assess at least 5 seconds, but not more than 10 seconds. Very good, guys. While performing cardiopulmonary resuscitation (CPR) on a 5-year-old child, the nurse should palpate for a pulse. So, which site is the best for checking the pulse during CPR in a 5-year-old child? Ladies and gentlemen, for looking for a pulse, palpating for a pulse, a 5-year-old child will be treated like an adult, okay? It's only in infants where we look at the brachial artery. So in this 5-year-old child, we'll be palpating the carotid pulse, okay? Thank you. So checking the carotid pulse in a child during CPR provides information about perfusion of the brain. The brachial pulse is checked in an infant because the infant's short and typically fat neck makes it difficult to palpate the carotid pulse. The femoral and radial arteries might indicate perfusion to the peripheral body sites, but the critical need for adequate circulation to the brain. Okay, great. Next is why should the nurse avoid palpating both carotid arteries at one time? Ladies and gentlemen, we are saying that when you are doing the palpation, never palpate the 2 carotid arteries at a time. What is the main reason? Yes, correct. Palpating both arteries at one time may cause severe bradycardia. Okay? So the nurse must palpate the carotid arteries one at a time to prevent severe bradycardia and impairment of cerebral circulation. The nurse must also remember to avoid massaging the carotid sinus that is usually located at the bifurcation of the carotid arteries because this one normally results in bradycardia and could lead to cardiac arrest. The next question is, we are saying that we are asking to assess the effectiveness of cardiac compressions during adult CPR. A nurse should palpate which pulse site? Very good, guys. You will still assess the carotid artery, which is more accessible, okay? So during CPR, the carotid artery is the most accessible and may persist when peripheral pulses, such as the radial and brachial, are no longer palpable because of the decrease in cardiac output and peripheral perfusion. So chest compression performed during CPR can preclude accurate assessment of the apical pulse. The last question, guys, I'm asking is the rapid response team has been called to manage an unwitnessed cardiac arrest in a client's hospital room. How long should the nurse estimate the maximum time a person can be without cardiopulmonary function and still not experience permanent brain damage? Very good. 8 for to 6 minutes. Okay? It's good to remember that after a person is without cardiopulmonary function for 4 to 6 minutes, permanent brain damage is almost certain. Okay? So to prevent permanent brain damage, it's important to begin cardiopulmonary resuscitation promptly after cardiopulmonary arrest. Okay? Thank you so much. Up to that point, we now wrap the video, and in the next video, we'll be demonstrating how to perform CPR. Okay? Thank you so much.